Okay, part three of chapter 28, reproductive system. I already talked about these hormones, and I mentioned that gonadotropin releasing hormone is secreted from the hypothalamus, and it's secreted in pulse. And when that happen, that will lead to stimulation of LH and FSH. LH specifically around day 14, it's going to be secreted more, massive release or sudden surge of LH from the anterior pituitary. And this sudden surge or sudden increase, massive release is going to lead to the ovulation. As I mentioned, it increased the pressure inside the mature Graafian follicle to push out the secondary oocyte, which will leave surrounded by some cells from the follicle, and we call that corona radiata. And remember, day 14 is called the mid cycle because the average is 28. So day 14 will be the mid cycle. Which cycle? Uterine cycle or ovarian cycle? Both of them. Both of them. They happen at the same time. Uterine cycle, which is also known as menstrual cycle, and the ovarian cycle, they happen at the same time. So when you say day 14, it's mid cycle. So mid cycle in the ovaries where ovulation is happening, and mid cycle in the uterus as well. And again, mid cycle of the uterine cycle, I mean, and this will lead to the ovulation. So the sudden surge of LH is going to lead to increased pressure in the follicle. It will rupture, causing ovulation, and it will also lead to completion of meiosis one. Remember, we stopped at meiosis one in the primary oocyte, so it's going to continue after that. When exactly does this ovulation occur? Like this high pressure enough to push the secondary oocyte? About 9 hours after that peak of LH. So again, gonadotropin hormone is released from the hypothalamus. It goes in pulse. It goes to the anterior pituitary. We talked about how it leads to LH surge. Also, it will lead to increased FSH. FSH will stimulate the follicular development. I talked about that, and the name gave it away. Follicle stimulating hormone. So what does it stimulate? Follicle. It's the name. And so every month, follicles are going to grow, grow, grow until you get to the tertiary. Tertiary will continue to grow under the effect of FSH that we're talking about right now. And its theca cells or thecal endocrine cells are the ones that are going to increase secretion of the hormone estrogen. It gave you like another hormone called androstenedione before it, but that's okay. Good enough to remember that the theca cells secrete estrogen. There is an intermediate, but that's okay. Um, so this estrogen, does it just go in the blood like that? No, exactly as we mentioned in the testosterone, which is the most important and the most common androgen. Here, remember, it was attached to a protein so that it prolong its lifetime or lifespan. Same thing here. Also, estrogen attached to protein, which is albumin. And it might be globulin as well, but it's a plasma protein anyway. Why does it attach to plasma protein? To increase its lifespan, to stay for more, to be more effective, to increase the concentration. Exactly the same as I mentioned about the androgen. So both androgen and estrogen, they have to bind or carried by a protein to increase its life cycle. Remember, I told you that androgen is a name that means any male hormones. Testosterone is the most important, most common one, but there is also other ones, like dihydrotestosterone, for example. Estrogen is also different types, like estradiol, estrone, and estriol. So estradiol is the main one, just like here it is. This is the most abundant one, just like testosterone is the most abundant androgen. Estradiol is the most important or the most abundant estrogen. This is how it looks like, but that's okay. Come from cholesterol and goes all the way. But the most important information is what we already talked about. So, what are the functions of the estrogen? Very close to the functions of androgen. So it does stimulate muscles and bones. In androgen, we said the same thing, but of course, the effect of estrogen on bone and muscle is not as strong as the effect of testosterone on the bone and muscles. That's why in males, bone and muscle are bulkier and stronger. But still, estrogen stimulate those two. Translation, it means if a lady doesn't have enough estrogen, her bone will become weaker and the muscles will become weaker. And this is exactly what happened in menopause. In menopause, estrogen goes down, the bone become weak, fragile, and this is what we call it osteoporosis, if you heard about this. What else? It will maintain female secondary sexual characteristics, also just like the testosterone. It's the same thing, but in a different way in the females. And you know what happened in a female? Changes that happen when a little girl or a girl reach puberty and start to change, and you see the different things like the hair also, just like males, grow in the armpit, grow around the genitalia. The adipose tissue start to uh, distribute in a different way, start to like increase in the area of the breast, and in other different areas of the body, as you know how females change during puberty. Any change that you notice at that time, these are called secondary sexual characteristics, and these are under the effect of estrogen, just like testosterone. It also affects the brain. We mentioned that testosterone affect the brain in a way that affect the behavior. Same things in female, which is a different behavior, but just like it also affects the sexual drive, which is called libido. It increases the sexual desire, of course. Of course, the sexual desire, if a lady doesn't have enough estrogen, sexual drive will be weak. Same thing as we mentioned in males, if a male doesn't have enough testosterone, his sexual drive will be weaker. Also, it maintain the accessory reproductive organs, which is the same thing as we mentioned in males, but these are different accessory reproductive glands. It also stimulate the endometrium, and this is the only one that's different because the uterus in females only. So it's initiate repair and growth of endometrium, which is the proliferative phase. We talked about this before. Um, so that was during the uh, the follicular phase, which is the follicles starting from primordial, primary, secondary, tertiary until mature Graafian follicle or mature tertiary release or kick out the secondary oocyte, which we call it ovulation day 14. So those first 14 days were the follicular phase. I'm sorry, the follicular phase, which corresponds to both menstrual and proliferative phase. Now, after day 14, this is a second phase. For the ovaries, it's the luteal phase. Remember, LH should increase, kicking out or leading to ovulation. And then corpus luteum now is there, stimulated by LH. It start to produce progesterone besides some estrogen, but it's more important. I mean, here it said that the progesterone is produced and formation of corpus luteum, and corpus luteum is the one that's going to secrete progesterone, which is the most important, plus estrogen. Estrogen will come from the ovaries anyway, but the additional one here is progesterone. And I told you guys that progesterone um, is progestation. Progesterone. Gestation is pregnancy. So progesterone means progestation, pro pregnancy. It help pregnancy. It prepare the endometrium for pregnancy, which is secretory phase. Proliferative phase, I talked about it before. Proliferative phase, I'm just refreshing your information. During proliferative phase, the functional zone of the endometrium proliferate or reform, means it becomes thicker and vascular. It becomes thick, and while it's becoming thick, blood vessels grow with it, and that's it. But in the second half, which is the secretory phase, it continue to do the same as proliferative plus secretory secretions, and these secretions will contain nutrients to feed uh, uh, the fertilized egg or the zygote that's expected to come. Is it coming or not? We don't know, but it has to prepare anyway. And what continue the function of the corpus luteum? It's LH. So here is a luteal phase, progesterone increase. It go to the endometrium, leading to secretory phase. So now you have both progesterone and progesterone and estrogen. So what if pregnancy occur? Corpus luteum will continue to support the functional zone of the endometrium, keeping it thick, vascular, and contain secretions, waiting for a possible pregnancy. What? So that's what's going to happen. Corpus luteum will continue if there is pregnancy, if there is fertilization, because the fertilized egg or the zygote, it's going to send a hormone that's called HCG, uh, gonadotropin, the human chorionic gonadotropin. We'll talk about it. But this hormone that's coming from the fertilized egg will maintain corpus luteum. It will keep it alive only if pregnancy occur. What if pregnancy doesn't occur? What's going to happen? Corpus luteum will shrink, degenerate, become white, not yellow anymore, and it will become white. We call it corpus albicans. So what will happen then? Progesterone and estrogen are going to drop because they were coming from the corpus luteum. Now corpus luteum is shrinking. It will drop. So what? So progesterone and estrogen that were supporting the thickness and the secretions coming from the endometrium, they will not support it anymore. So nothing to tell the functional zone of the endometrium to continue. That there should be a continuous stimulation to stay. Once you remove the support from it, from progesterone and estrogen, um, now it's not supported anymore, and it will start to shrink, and blood vessels shrink. So no enough blood supply coming to the functional zone. It will start to slough off, and here we come to the beginning again, which is the menstruation. When that happen, when the progesterone and estrogen drop, negative feedback will lead to gonadotropin releasing hormone pulse again, and this will start the process, which is FSH secretion, follicle stimulating hormone. Now you are at menstruation. So after menstruation, you need to rebuild, which is the FSH. At the same time, ovarian cycle will begin again. So all of this happen at the same time. Uh, the endometrium, here this part is follicular phase, luteal phase. This is the ovarian cycle. At the same time, the uterine cycle is happening. But look at this: primary, secondary, tertiary, mature Graafian follicle ovulation. That's day 14. Look here, the red, sudden surge. Uh, Estrogen also increase. Yeah, that's okay. I mean, gonadotropin releasing hormone. Yes. How about FSH? Yes. But what's the most important here? LH. Look how it's become all of a sudden surge, very high increase, and this will coincide with the ovulation. And because of that, because of the kicking off the secondary oocyte, and look, corona radiata surrounding it. So this is exactly the mid-cycle. From here to here, this is the first 14 days from ovulation to the end. This is the second 14 days. So 28 day will be here. Here is the corpus luteum, and you see how progesterone and estrogen are increasing. And then it will mature, even secreting more. Pregnancy, it will continue. No pregnancy, here is corpus albicans, drop. So here it is one more time, repeating the same thing again. Estrogen and progesterone. What's the most important here? Estrogen is for proliferative phase, rebuilding uh, the sloughed off or rebuilding the functional zone of the endometrium that was sloughed off during menstruation. Estrogen comes first, leading to proliferation or rebuilding of the functional zone of the endometrium. It will grow, grow, grow until day 14. Day 14 ovulation, corpus luteum secrete progesterone, and progesterone will lead to the secretory phase. If there is no menstruation, these two are going to drop, as I mentioned before, and this will lead to the functional zone is not supported anymore. So shrinking of the vessels, no enough blood supply, sheds off, menstruation start, which is what I talked about before. So it will continue to shed off for a couple of days, can be like 3 to 5, sometimes more, sometimes less, but this is the average 3 to 5 days. After which there is no functional zone anymore, and the cycle will repeat itself. During a uterine cycle, this is what I mentioned. Progesterone, proliferative phase, estrogen. Secretory phase, progesterone. Here it is. Or both of them, because estrogen will continue anyway. So proliferative phase due to estrogen. Secretory phase due to mainly progesterone. Estrogen also to keep it thicker, but progesterone is secretory. So the most important I want you to remember here is proliferative estrogen, secretory progesterone. Estrogen continue anyway, but this is the bottom line. Effect on the body temperature. The fluctuation of these hormones in females during the cycle is also accompanied by changes in the body temperature. During the luteal phase, remember this is where the progesterone dominates. And during the follicular phase, it's estrogen. Follicular estrogen, which coincide with proliferative. Luteal progesterone, which coincide with secretory. So during the follicular phase, the body temperature is going to drop about zero point 0.3, which is hard to notice, but physiologically it does happen during the follicular phase. Um, During ovulation, it drops a little bit, but a day after ovulation, the temperature rises. And this is an important one, and it will continue to be rising. So, what is the importance of that? Why one day after the ovulation temperature increase? Uh, uh, um, this is something that tells the girl or the lady that this is a time of ovulation. So if she wanted to know, this is one of the things. There are several things, but one of them is if she during that time, like she know this is around day 14, plus or minus, she doesn't know. So if she measure the temperature and find it rising, because before that it drops. After it drops, it will rise. If that happen, it means this is the right time. This is the ovulation in case if she's trying to conceive. Here is a menstrual cycle. Again, cycles coincide with each other. Remember that. So here, from the beginning until this half, this is the first half, 14 days, and this is the second half right here. First half is two parts. Functional zone uh, is going to slough off destroy menstruation. Until here, there is no functional zone. At this time, estrogen will come and look, now we are here. This is called the menstrual phase right here until this point. So slough off, slough off, slough off, slough off. Until this point, the functional zone is gone. Estrogen will increase after that. Why estrogen increase? Because of the uh, increase the gonadotropin releasing hormone at this time, leading to increase follicle stimulating hormone. Follicles secrete estrogen beside it's coming from the ovaries anyway. So it will start to rebuild the functional zone. Rebuilding, we call it proliferative phase. And this coincides with estrogen, which is the follicular stage in ovaries. At day 14, what's the major event here? Sudden surge of LH, ovulation occur, and corpus luteum form, secreting progesterone, and here is the secretory phase because of the progesterone. But look at this increase in the body temperature right here. Day 14 it drops and then go up. So when a lady find that her blood pressure drops and then increase all of a sudden, so this is the perfect timing for ovulation, which is the perfect timing for possible pregnancy if she's interested. Now the sexual function. Sexual function, the whole process of sexual intercourse is under the control of the autonomic nervous system, both in males and females. So what happened during sexual intercourse? Of course, there is first sexual stimulation in the beginning, which is parasympathetic, take the upper hand, and then it will be followed by the sexual intercourse itself, which is introduction of the penis inside the vagina, so that the semen is introduced into the vagina, and then it will move through the her reproductive system. And I talked about that before, but the coordination here of the nerve or the control of this process, it's coming from both sympathetic and parasympathetic. So the first part, which is the arousal itself or the sexual stimulation, parasympathetic. Sexual arousal or stimulation is parasympathetic. So what happened in parasympathetic? Erection, which is basically arterial supply. There are arteries going to the penis and veins leaving the penis. Erection is under parasympathetic, remember, parasympathetic, erection. So sexual stimulation, parasympathetic take the upper hand. It's going to secrete something called nitric oxide. Nitric oxide. Parasympathetic lead to nitric oxide. Nitric oxide is vasodilator. The arteries dilate. More blood goes inside the penis, inside the erectile tissues specifically, and the veins are constricted. So the blood is trapped inside the penis, and the penis become stiffer, larger and stiffer. And this is the process of erection. And again, it's parasympathetic nitric oxide. So during the sexual stimulation, also the bulbourethral glands, remember these glands we talked about, the seminal vesicle, that's one, prostate, that's two, bulbourethral, that is three. It's between the bulb and the urethra. And this is going to start to secrete some secretion, a little bit of secretions. And these secretions will lubricate uh, the spongy urethra, but it also lubricate the glands. When the glands is lubricated, that will facilitate the sexual intercourse. And after the sexual stimulation, sexual intercourse occur, and after that there will be emission and ejaculation. These are two separate processes. Emission, now all of what we talked about so far in sexual stimulation, erection, and even secretions from the bulbourethral gland, lubrication, all of this is parasympathetic. And then second part is emission and ejaculation. This is the next part, and this is sympathetic. Sympathetic will lead to peristaltic contraction of the ampulla. Remember that ampulla at the end of the ductus deferens or the vas deferens. These are going to contract so that the semen that's in there is going to be pushed out and go into the prostatic urethra. The gland, seminal gland, is going to also contract. Prostate contains some smooth muscles contract, pushing the semen from all these glands into the urethra. And in a spongy urethra, uh, the semen will be pushed out, and it should go to the vagina, which is ejaculation, which is the next one. So emission is not into the vagina. The emission is just starting from the ampulla and moving prostate, seminal gland, all of these, ampulla, prostate, and seminal gland, seminal vesicles. All three are going to contract, leading to that seminal mix to be pushed out into the urethra. That's it. When it leave the urethra, that's the or when it pushed out, this is ejaculation, which is the next part. At the same time, remember that in males only, the urethra is serving the function of urinary system, delivering the urine out, and reproductive function as well. So as the semen that's moving into the prostatic urethra, it should go down in a spongy urethra, but what if it goes up, entering the bladder? No, that's not going to happen because sympathetic also close the internal urethral sphincter so that the semen doesn't go to the bladder. Ejaculation is the next part, which is uh, contraction of other parts. You want it to ejaculate the semen out. It is already in the urethra. You want it out. So the muscles here are called cavernosus and bulbus spongiosus. Cavernous and spongy. Remember these, the the uh, the erectile tissues. The muscles in these tissues are going to contract. The penis it's already stiff. It becomes stiffer at this point, and because of these contractions, the urethral opening, external one, is going to open, and the semen will be ejaculated out, and this is accompanied by the orgasm. The orgasm is that intense pleasure that happened during that ejaculation. After ejaculation, everything will go back. It's over. So we call it the resolution phase. Heart rate that was increasing during sympathetic, during emission and ejaculation, both of them. Now it's already ejaculation is done. So resolution, which is the heart rate and the blood pressure drops, that was increasing during sympathetic, and blood leave the erectile tissue. Now the penis returned back to its original status, which is called detumescence. Detumescence is losing erection. It's not stiff anymore. It returned back to the normal shape. Um, imp Impotence is something that's different than infertility. Impotence and fertility. These are two different things. Impotence is impotent. Potent mean fit, good, everything is working. Impotence means not potent, not working. It's erectile dysfunction. It have nothing to do with the infertility. So the problem is not in the sperms, the problem is not in the glands, the problem is not anywhere else. It's just inability to either achieve or maintain. He cannot start the erection, or he does start the erection but cannot maintain enough to finish the process of sexual intercourse. So any one of those is impotence. What if this male can get the erection and the penis is stiff and everything? That's not enough. Does it continue until the end or not? Whether it doesn't start in the first place, erection doesn't start, or doesn't continue enough to finish the process, we call that impotence. Can be due to psychological factors. This is a lot. Sometimes it's a physical factor in the blood supply, in the nerves, so whatever it is. There are different reasons for that, and it can be treated most of the time. For the females, it's basically the same thing. Sexual excitation starts with parasympathetic as well, and this will also lead to engorgement, which is something similar to erection. There are erectile tissues in females as well. It's not the same. It's not the same, but it also the same idea. Blood supply increase in these erectile tissues, same way. Blood goes in, it doesn't leave. Yes, it does happen and increase its size. Um, and at the same time, the secretions inside the cervix is going to increase. Secretions increase from the cervix, cervical glands, and the vestibular glands that I talked about before. How about the vagina? Yes, the vagina will be lubricated, fluid move into it, and the blood vessels in the vaginal wall start to increase. It become filled with blood. And there will be secretions in the vagina to facilitate the process. So in males, remember what facilitates the process, what causes lubrication? It's a bulbourethral gland. Here in females, there are different glands that also do the same job. The cervical gland, the vestibular gland specifically, do the same job of lubricating the vagina. Orgasm is also just like males. Remember, there is peristaltic contractions in males. But in males, it was the ampulla, the prostate, the seminal vesicle, which is not in females. Here it is more of the peristaltic contraction is of the uterus and the vagina. And then the same names of the same muscles, bulbospongiosus and SQ cavernosus. There is spongy and cavernous, yes, but it's not like this long bodies like in males. It's something smaller. Remember, I told you guys that both reproductive organs of males and female, they start, the beginning is the same, but they change, they grow, and it end up having a different shapes and different structure. So this is for the sexual function. Now, contraceptions. Contraceptions is basically what can be done to prevent pregnancy. There are different ways, and we're not going to go into the details. It's abstinence, which is basically ladies can know when is day 14, the mid-cycle. So absence from like 3 days before, 3 days after. Avoid that time. This can be used. It's not very accurate, but this is one of the reasons. Barrier can be used like the condom, like the cap in females, different things. IUD, it's a device that can be inserted into the uterus of females to change the consistency so sperms cannot move inside. It will kill it. They usually put some chemicals in it, changing the structure, and this will prevent the sperms will be in the vagina anyway, but it cannot move within the cervix and the uterus. So there's no way it will reach the fallopian tubes for conception, but it's not 100% accurate. There is a chemical way they can add chemicals. There's a surgical way they can cut or mm, obliterate or close the vast difference in males or others in females. Anyway, there are different ways. Infertility is different than impotence. I just told you guys. Infertility and impotence are completely different things. Impotence, unable to start or continue, erection. Infertility is something that's completely different because you cannot achieve pregnancy. Uh, and in order to say that, it's not like once or twice or month or something. It has to be for a whole year of normal sexual intercourse that's unprotected without using anything. If it had for a whole entire year, we call it infertility. And infertility can be coming from males or females. They usually start with male, followed by females, and there are different ways. I'm not going to go into the details, but again, I just want to emphasize the difference between erectile dysfunction, which is the impotence, versus infertility. So, can it happen that a male, for example, he's okay for the erection and he can start and he can continue the whole process until the end of the sexual intercourse, everything is perfect, and then he's still infertile? Yes. Maybe the sperms are bad, but everything before that is fine. So these are two different things. Infertility is for pregnancy. For females, there is amenorrhea. We talked about menstruation already, the sloughing of the functional zone of the endometrium. A means no, menorrhea is menstruation. There is no menstruation. There are two types. If this is a girl that's at puberty already and she didn't even start any menstruation at all, she didn't even start, she didn't initiate. Did you have it before? Never. This is called primary amenorrhea. Secondary amenorrhea or transient, it means she used to have it and now it stopped. Stopped for how long? At least 6 months. You can't say like she's having secondary amenorrhea. She didn't have the period for 3 months, for example. No, we don't call it amenorrhea. It can be any other changes or whatever happening. It has to happen for 6 months after she used to have it already. So she used to have it and then stopped for 6 months or more. And there are many factors. Maybe she's losing weight, emotional status. It can be anything. But just understand the idea of amenorrhea, no menstruation. And this is different than dysmenorrhea. See the difference? A versus this. A, no. DYS, painful. Amenorrhea, no menstruation. Dysmenorrhea, painful menstruation. Sexually transmitted diseases are any diseases that can be transmitted through sexual intercourse from male to female or from female to male. There are a lot of things. Some of them are viral, some of them are bacterial, some of them are fungal that can be transmitted from either male to female or vice versa. And there are a lot of things, including some forms of like hepatitis and AIDS and many other things. It can be bacteria as well, something like syphilis, like something like gonorrhea, and so on. But the most important one or the most common one is called chlamydia. This is a bacteria. And the problem with chlamydia is because it can cause something called PID or pelvic inflammatory disease. Chlamydia is one of the bacteria that can be transmitted. Why this is specifically important? Because it's very common, or it's common in general. It's more common than others. This is how we should say it. It's the most common among the other forms. And it can be chronic and it leads to pelvic inflammatory disease or continuous inflammation in the pelvic region. And this can cause fibrosis and destruction, so it can lead to infertility. Um, Development of genitalia um, during embryo, 5 to 6 week, like until a month and a half. It's not different. Both of them are the same. Are the same. Uh, Gonads, same. Internal, external, same. Very similar. No difference. And then, if it is a male, it means it's XY. So there is Y, and this is a difference. In females, it's XX. There is no Y. So if there is no Y, the organs are not going to develop into the male reproductive organs. If there is testosterone, so what's default? female will form. That's the normal, unless there is testosterone. So if you leave it alone, it will become female organs. If there is testosterone, the male reproductive, so the whatever that was there until a month and a half, if there is XY, so there is Y, so there is testosterone, it's going to grow and become female. If there is no testosterone, it doesn't grow as male and it will grow into female. So by default, it becomes female. If there is testosterone, it will become a male. So here it is in the beginning. Both of them look the same thing. It looks like this. And then if there is testosterone, it's going to grow as male. If not, it will grow as a female. So this is what's going to change. And this is what I was saying, that they come from the same origin. So the penis is equivalent to the clitoris. Like if there is no testosterone, it will become clitoris. If there is testosterone, it's not, it's going to grow more, and instead of being clitoris, it will become the penis, and so on. It can grow as female if there is no testosterone. I told you guys before that the testes form beside the kidneys, and there are fibrous tissue, gubernaculum. This is going to pull it down all the way into the normal location, which is within the scrotum. Is it already in the scrotum? No. It in the beginning it is right beside the kidney. It descend because there is gubernaculum that pull it down all the way. So it starts to pull it down because of the hormones, and each one of these testes will end up being in one of those two scrotums. If this doesn't happen, we call it undescended testes. And what's the issue with undescended testes? What if it doesn't descend? It will stay beside the kidney, or not necessarily. It can be pulled down and it doesn't go to the testes. It can stay like in the inguinal canal. It just doesn't. If it doesn't end up in the scrotum, we call it undescended testis. Specifically, if it is inside the body, there is extra heat, or the body temperature is a little bit higher, and this is not good. I talked about that. It's not good for the function of the testis, both for the hormonal secretion and for the sperm production as well. We call that undescended testis. Effect of age, of course, most importantly, hormones drop, and because of the hormones drops in females, later on she will get into menopause, and menopause is two parts. Meno is menstruation, pause is to stop. This is where the menstruation stop, and what happened here is all follicles are gone. No more follicles. And that's what the change that actually happened in males. The change is more gradual because the hormones drop, but changes are more gradual. And for females, remember that when menopause come, uh, follicles are all gone, no more follicles. Estrogen drop, and estrogen was responsible for different things, including maintaining the feminine or the feminine uh, appearance, supporting the different parts of the body. So when that support goes away, there will be changes in the body, including the bone. The bone will become weaker, which we call it osteoporosis. Um, so there is also andropause in males. So andropause versus menopause. And this happened in males in the age around 50 to 60, so it's later than females. And basically, same idea. In females, estrogen drops, in males, testosterone drop. And FSH, LH, by negative feedback, they are going to increase. Um, Unlike in females, all the follicles are gone. In males, it's different because the sperms will continue to be formed. Less, yes, Less active, yes, but it will continue to be secreted and maturate. So it's not exactly the same as what's happening in females. Perimenopause, peri means around. Menopause is so menopause, of course, we know. So this is three parts: peri, around, menopause. We know that menopause is stop menstruation. Peri means around it, before and after, specifically before. There are some changes that happen to the ladies, and she will understand that she will get into menopause very soon. These things are including uterine cycle become irregular, ovarian and uterine cycle. Like every female know exactly how her uterine cycle looks like. It's like around 4 or 5 days. The period is about 4 or 5 days, or the menstruation is about 4 or 5 days. Now it is one time it's one day, one times it's 8 days. It come like in fixed intervals, like every 4 weeks. One time it come after 2 weeks, one time it come after 2 months. So these are the irregularities. And of course, estrogen is going to decrease because she's getting closer to the menopause. Because of that, ovulation will not be triggered and there will be no more oocytes, secondary oocytes. So here in menopause, unlike males, this is like 5 years earlier in females. And again, the most important thing is all primordial follicles are gone. That's it. Most important. No primordial follicles. So none of them is there. There is no follicles. There is no ovulation. Estrogen drops. Uh, Sometimes menopause, it happened during like 40 to 50. Sometimes, if it maybe in some females, the follicles are gone before the age of 40. That's not normal. That's what we call it premature menopause. And if that's the case, same thing, estrogen drops, progesterone drops, and by negative feedback, all the hormones that were stimulating this process are going to increase. So what's the problem with estrogen if it drops? I told you guys already that estrogen was causing the female body to continue or to maintain its femininity. So now the uterus is not supported anymore. The size drops. Breast is not supported by estrogen anymore. It start to shrink. The vagina and the urethra was supported, start to become thinner. The bone was also supported by the estrogen. It become weaker. The position decrease. It become weaker, and it can be more fragile, which we call it osteoporosis. By the way, just for your information, many ladies choose to get estrogen replacement therapy or ERT in order to avoid specifically the bone being too weak. There are pros and cons, but I'm not going to talk much about that. You can read about it if you want to. And normal reproduction, in males, it's required sperms to be enough. pH is good enough, which is slightly alkaline. It has to have the nutrients. So there are factors. He should have normal erection, normal emission, normal ejaculation. So basically, all these that we talked about should be normal. If one of those is disrupted or not normal, this can lead to either erectile dysfunction or infertility. In females, same thing: ovaries, uterus, the vagina, the different glands, secretions, because it's both males and females. They usually start with male first to make sure that everything is okay, the semen is okay, everything is right, sperms are good shape. And so if not the case, they start with the female to see what's wrong. Is it the ovaries? It's the uterus? Is it the vagina? Is it the secretions? And so on. Um, if both of them are okay, the secondary oocyte is released, picked up by fimbriae, moving down, and then if the sperm is coming from the other side, fertilization occur in the fallopian tube, and the zygote will form, and the zygote will move into the uterus, attach, make the placenta start to grow into an embryo, and then the embryo, which is the first 2 months, the embryo will become fetus from the beginning of third month until normal, which is 9 months. So I mentioned that before. Embryo versus fetus. Embryo is first 2 months. Fetus is the remaining until week 9. And this is the integration of different systems. All systems integrate with each other. I'm not going to go much into this. Uh, it goes without saying. So this is the end of the chapter 28.